Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning. We're recording this on Tuesday, March 17th, just for a time stamp. This is going to be released at 7 a.m. on the 18th. So you're probably listening to this after the 18th, or you're definitely listening to it after then. We want to talk about a couple things today as far as updates go. We're going to talk about treatment and emerging evidence for certain medications. What we're learning is changing daily. And then we're going to talk about a lot of questions we're getting, some frequently asked questions from patients, and then we have a few from Instagram as well. We're going to talk about just the ones we think are most pertinent to everybody. And then we've gotten so many questions, we're going to do a longer video and then put it on our website if you're interested. So we don't want to take up a ton of your time. We're going to go over what we think are the most high yield first. So let's jump into kind of treatment and medication updates. Mike, there's a lot of discussion around ACE inhibitors and ARBs. Do you want to talk a little bit about the controversy there and whether or not people should be using those? And this is mainly, I guess, we're talking to physicians at this point, but it's probably good information for some people in the general public to know as well.
Yeah, no, I think it does speak to the public as well, because there's a lot of concern out there about ACEs and ARBs, which are two blood pressure medications. ACE stands for angiotensin converting enzyme inhibitor, and ARB stands for angiotensin receptor blocker. These are things like lisinopril, losartan are two really common ones, and millions and millions of Americans are on these medications currently. This is a really complicated topic, so let me say that up front. I'm going to try to simplify it as much as possible so that it is understandable. The story starts way back a long time ago when we realized that angiotensin 2 was involved in the progression of lung injury in viral illnesses. I remember back in the early 2000s, we were talking about this as a possible target for influenza-based ARDS, or acute respiratory distress syndrome, or progressive pulmonary disease. So initially, ACEs and ARBs started off as a possible target for treatment in COVID-19. And an article was released in Lancet, which was actually a letter to the editor that actually suggested that ACEs and ARBs might be a bad thing in COVID-19. And that's because, interestingly enough, the coronavirus attaches to the ACE2 receptor in the cells of your lungs and in your gut, and that's how it actually binds to the cell and how the virus gets into your cell cytoplasm and starts to reproduce. So it's actually through the ACE2 receptor, which is obviously related to this whole angiotensin pathway, that the virus can actually get in and reproduce within the cell. So the people in Lancet said, well, look, there's been some mouse and rat studies that suggest that taking an ACE inhibitor or an ARB increases the number of these receptors that coronavirus can attach to. So that's where the concern all started. There is absolutely no data, with the exception of those 3 mouse studies, that you actually get an increase in your receptors in those tissues. So let me speak to it a little bit more. Angiotensin is a chemical that is produced in your body and is converted to angiotensin 2 in your lungs. Angiotensin 2 is bad for a number of reasons. It's bad because it increases blood pressure, increases your risk of cardiovascular disease, causes vasoconstriction. We think that those actions are a lot of the reasons that people develop progressive lung injury with these viral illnesses. So theoretically, reducing angiotensin 2 would be a good thing. As I mentioned, it's complicated because a downstream enzyme that converts angiotensin 2 to a less deleterious form of the protein, what's called angiotensin 1 and 7, is the ACE2 enzyme. The ACE2 enzyme sits on the cell wall and converts basically angiotensin 2 as it's passing by. As it's sitting there, though, the spike protein, or the little proteins that stick out from the coronavirus, why we call it the coronavirus in the first part, that's called a S protein or spike protein. That protein attaches to the ACE2 enzyme itself, gets sort of degraded, and then both of them get kind of taken into the cytoplasm of the cell. So there have been three studies that suggest that taking ACEs and ARBs leads to an increase of ACE2 receptors on the cell cytoplasm. These were in mice and rats, published in the early 2000s, 2004, 5, and 6 were the three studies. And they were all in heart tissue, so none of this in lung tissue, unfortunately. Subsequently, there's been two additional studies that say there was no change in the number of ACE2 receptors after taking ACEs and ARBs. Those were also in mice and rats. But interestingly, if we actually look a little bit closer at the data, there's actually two human studies that suggest that you don't get any increase in ACE2, taking ACEs and ARBs. That's, in my mind, better than rat studies, although they were just looking at plasma levels. They weren't actually biopsying tissue like they were in the mouse and rat studies. But there are also, probably most importantly, so if you just ignored everything that I just said, there are two studies in humans, specifically in SARS viruses. So one of them has been released in the COVID-19, and that was a very small study suggesting that there were higher levels of angiotensin 2 in people with progressive disease. And there was also a mouse model from the SARS-1 virus back in 2005 that showed that the mice taking ARBs, angiotensin receptor blockers, had a decrease in lung injury. And what we think is probably happening is that the angiotensin receptor blockers are actually helping to decrease the number of ACE2 enzyme on the available on the cell wall for the coronavirus to attach. And we may actually be seeing a decrease in lung injury because, one, we're getting less vasoconstriction, less inflammation within the lung, and two, because the coronavirus can't attach as well. This is mostly conjecture at this point, but it is strong enough conjecture that there's actually two studies going on right now. One is a pilot trial looking at giving recumbent ACE2, which is just basically, imagine instead of having all of this enzyme on your cell wall, if you just gave somebody a ton of ACE2, you're almost kind of using it like an antibody, blocking the coronavirus so that it can't attach to your cell walls. And then there's also a randomized controlled trial at the University of Minnesota that is looking at actually administering losartan, which is an angiotensin receptor blocker, to patients, and seeing if they have a reduction in progression to lung injury. So I know that's really complicated, but the whole area of this sort of complicated process brings up four potential therapeutics that we could consider. One is if we block the spike protein with a vaccine, that's a very viable way to prevent viral basically viral integration into the cell cytoplasm. Two, we could actually inhibit the enzyme that has to help the ACE2 bring the coronavirus into the cytoplasm. That's called the TMPRSS2, which is a serum protease. That can be blocked and has been shown in the past to be blocked by a chemical called camostat mesylate. So that's a potential treatment therapeutic. Three, we could just block the ACE2 receptor, and it looks like we could potentially do that by administering ARBs, or at least that's the theory, angiotensin receptor blockers like losartan. And then four, we could actually deliver ACE2 to the patient and try to block all of those spike proteins on the coronavirus. So lots of potential options here for interventions and future therapeutics, a lot of which are just empirically being used right now, and a few of which are being actively studied.
Okay, Mike, so you're obviously talking to physicians there. I'm going to be a patient right now and ask you a couple questions. I mean, everyone that's not a physician is probably already turned off at this point based on that. But in case anyone is still listening, if I'm a patient and I get symptoms, should I start taking an ACE inhibitor?
I don't think so.
Great.
No, I don't think the data is quite there yet, but it is encouraging, and there's definitely studies going on right now, so that's likely going to change very soon.
What if I'm already taking an ACE inhibitor and I don't have symptoms? Should I stop or should I continue?
I would not stop.
And
I would not
what
stop.
if I?
No, I don't think the literature supports that there's any increased risk for getting the virus.
And what if I get symptoms and I'm taking an ACE inhibitor? Anything to change?
No, I would keep taking it the way you're currently
So
taking
if I'm a
it.
patient, I'm not changing anything. I'm not starting this. I'm not stopping this at any point right now. We're still just waiting for data.
I can't recommend any. I mean, we don't have the literature to back up any recommendation about starting or stopping an ACE. I don't think that. I will say that I am more encouraged by this than discouraged. So if there's anything I can do, it's sort of reverse the public opinion that's currently out there suggesting that you should stop taking your ACE or your ARB. In fact, I think I'm more encouraged that that's going to be a possible therapeutic adjunct rather than something that's going to increase the risk of getting the disease, which is what's being reported in the media and what's currently everybody's concern.
What about any recommendations about changing from an ACE to an ARB? Any thoughts there?
No. I don't think that's clear yet which one could be more beneficial. I think the theoretic benefit may be greater with an ARB, but I don't think there's definitely data to confirm that right now.
Yeah, it's interesting. Like I think a month ago, everybody was really excited about this as a therapeutic, and then a couple weeks ago, everybody was really worried that it may make things worse. And now it's really unclear, and it sounds like you're encouraged. So definitely nothing to do. We're just going to watch this space, and we've got great minds around the world working on this. So let's get a little more straightforward and talk about things that people actually could do something about or may actually have an effect on their decisions. A couple other questions that we've gotten from patients and kind of hot topics are steroids. Steroids are interesting. We use them quite a bit with pneumonia, with other respiratory illnesses. It seems like, though, with steroids, that early administration of steroids may actually increase some of the viral shedding and make someone a little more contagious if you take it during the replicative phase of the disease. So most people, I think right now, and again, this is evolving, are not recommending early steroids for these patients. Yet at the same time, there was a study just published in JAMA, and this is fascinating to me because normally we say a new study and we're talking in the last 3 to 6 months. So this was published on the 13th of this month, a few days ago. It was a retrospective single center study, 201 patients with COVID-19 pneumonia. And they actually had improved mortality when they were given methylprednisolone, which is an IV steroid. This was interesting, and again, these studies are, they're hard to interpret because the data it's not randomized, it's not controlled. But this was interesting in that because you would expect actually getting IV steroids, that cohort of patients, there's probably some selection bias. They were probably sicker to begin with, and you would expect them maybe to do worse, but they actually did better. So in my mind, it's kind of a stronger association that there may be some benefit to steroid later in the course. Now we're probably talking about, I don't know the exact numbers in those 201 patients, but probably a lot of them were intubated, which means they're not really respiratory shedding quite as much. So there's not that issue quite as much, and they're in the hospital. So, and there's also, we know with ARBs, which is what we get with this disease, that there's potentially low-dose corticosteroids can cause elevated inflammatory markers. So this is pretty unclear in general. It seems like in China, they were having some success with giving IV steroids, potentially decrease mortality, but early in the disease, not so much. So I guess the way to translate this is if you're at home and you're wondering about this and thinking about this, steroids is probably a bad idea. If you're just coming into the hospital or being treated by a primary care doctor kind of in the community, steroids probably a bad idea. But once you're in the ICU, if you're an intensivist, then you're probably going to have really good information. The most cutting edge in your hospital is going to have a protocol, so you can follow that.
What about ibuprofen, Matt, along the same lines as the steroids? Similar sort of mechanism of action.
So just in general, we don't know, but I think I would recommend our patients probably, if they ask us, to probably not take ibuprofen at this time, early in the disease.
I view that kind of like steroids too. I'd say the same thing. You know, if it's a low-grade fever, even if it's a moderate fever, you better just hydrate up, rest, and do what your body's trying to tell you to do, which is get better. So that's the advice I would give to our patients for sure.
I was just going to say, we know that, ibuprofen has an anti-inflammatory sort of effect. So if your goal is to decrease your fever, Tylenol does not have that anti-inflammatory effect. And we don't truly understand how important our own immune system is at this point in terms of preventing disease. And I think, this makes sense if you think about it as early on, your immune system, is important for fighting off the illness and preventing the progression to worsening disease. So why would you want to inhibit it with steroids or ibuprofen? So I think it makes sense to, stick with Tylenol early on in the disease. And then later on, if things do progress and your immune system is overloaded and you get this, acute respiratory distress syndrome, which is, inflammation related, then maybe it makes sense at that point to try to slow down the immune response. But early on at home, when you're treating yourself, it makes total sense to me to avoid anti-inflammatories like ibuprofen and steroids.
So let's jump into some pretty straightforward questions, not straightforward questions, but things that are more applicable. People are actually asking us quite a bit. Instagram questions, someone said, should we take additional vitamin C and zinc? I'll talk about vitamin C real quick and then get you all's opinions on zinc. Vitamin C it's a low risk thing to take. I mean, this morning I took a fair amount of vitamin C. I think the data on improving your immune system is pretty good. Now, whether should we take it if we're infected with the disease, there was a multi-center trial, the Citrus Ali trial, that showed some improved mortality. This is a multi-center trial, but there are a lot of issues with that study. I think the question of whether IV vitamin C, which is what this trial was about, in the hospital to help patients with this, that data is not great at all, and there's tons of debate. So I don't know if we should be using IV vitamin C. Now, just taking oral vitamin C, like I mentioned, I think it's a really low-risk thing, and it's a really cheap supplement. I think there's very little harm, and I think you'd be fine taking a somewhat large dose of vitamin C. Mike, do you have any thoughts on zinc? Zinc seems to be one of the things that's really helpful, like we talked about on a previous podcast with chloroquine.
Yeah, I'm not overly confident that zinc by itself is going to do much unless you're deficient in the compound. There are some patients who have a receptor malformation where basically it's a polymorphism in your genetics that your cells don't get zinc into the cytoplasm quite as well. So those patients, I think, definitely should be taking zinc to try to maximize the transport of zinc into the cells. If you're otherwise, fairly healthy, you don't have that polymorphism and your zinc levels are normal, there's probably low benefit. There is the interesting study that, or the theory that's come out that chloroquine acting as a zinc ionophore can actually get zinc into the cytoplasm at a higher rate, which can decrease the replication of the viral RNA. So I do think if it were I to get sick, I would probably start chloroquine along with zinc as a potential therapeutic measure, knowing that there's fairly low risk of both of those interventions. I think in general zinc is low risk, just like in general vitamin C is low risk. The actual benefit is unknown at this point of both of those compounds, but there's very little harm in taking them on a daily basis.
Yeah, that's a great point about the polymorphism. If you're one of our patients, it's SLC 30A8, the polymorphism that has to do with zinc transport, and you're probably taking zinc if you have that polymorphism as one of our patients. But if you're not one of our patients, you can just Google that. So Google that, SNP, find the RSID, and you can search it through your 23andMe or your other raw data if you've got that.
And it's a pretty common one too.
Yeah, we see it quite a bit. Yeah, for sure.
Yep.
What is the approximate percentage of patients that get lung damage? This is a question on Instagram.
By lung damage, I'm going to assume they mean acute respiratory distress syndrome, which is the progressive lung injury that comes from the viral pneumonia. About 5% of patients, and that's a pretty strong estimate based on the literature, but about 5% of patients are progressing to ARDS. If we extrapolate the data on ARDS, not from COVID, just from all patients who develop ARDS, which is a fairly ubiquitous thing in medicine that we see quite a bit of outside of COVID-19, if we extrapolate that data and follow up those patients for about 3 years, somewhere around half of those patients are going to have mild abnormalities if we do pulmonary testing on them. Around 12% get a reduced diffusion capacity, so 12% of them don't really diffuse the compounds in the air through the lung tissue quite as well, and about 45% of those patients are going to have decreased gas exchange during exercise. So it's not a disease that is that's very good from a morbidity standpoint. There are plenty of people who leave the hospital not on oxygen and don't require oxygen, but if you actually do the testing on their lungs, there is some residual damage in a lot of those patients.
So sauna, this is a question we're getting quite a bit now, and we're big proponents of sauna in general for overall long-term health. So someone asked, does sauna kill the virus? And as we answer this question, I think we have to answer it very specifically, not to cause any confusion. It seems like most viruses, the flu virus, for example, is killed around 60 to 65 degrees Celsius, which is about 140 to 150 degrees Fahrenheit, which is a reasonable temperature in a sauna to get to 140 to 150. So what this means is if you had it on your clothing or on your skin, it probably would kill those virus particles. But if you've already infected, you're not getting 140 to 150 degree temperature in your lungs. That's not going to happen. So this is not a cure for COVID-19. It's not going to speed your recovery probably by the heat killing the virus inside of you. But if just the question is, does that heat kill the virus? Probably. I saw some data that's interesting about this. I think this data was misinterpreted a little bit, but I saw where it seems like it replicates best up to around 8 to 9 degrees Celsius, which is around 47 degrees Fahrenheit. And a lot of people interpreted that to mean when the weather warms up, things are going to get better. It doesn't just start dying automatically at 47 degrees Fahrenheit. It may be a little more heat sensitive than the flu, which means that 140 to 150 degrees in the sauna probably does kill the virus in general, but again, not inside of you. So if you come home and you've been in an ER shift or something and you want to just get in the sauna because it's relaxing and that may kill some virus particles on your skin, sure. I don't think it's going to hurt anything, but it's not going to help you if you're already infected. Which brings up another interesting question we got about, I think I saw a question we got about, can you get infected through the mail? Was that a question that we had, Mike?
Yeah, that was one of them. It was like, can you get the infection from home delivery or letters in the mail or boxes from delivered? And the answer to that is we don't know really. I haven't heard of any specific cases where someone has gotten the infection in that manner. But what we do know is that there's been some data released on the viability of the virus on different compounds. And we know that it's viable for probably up to about 8 hours on cardboard, about 24 hours on steel, and up to potentially 48 hours on plastic. Unfortunately, there's no data on how long it's viable on your groceries. Like, I don't know how long it's living on your banana, but it's probably somewhere in that realm. So I think it depends on who you're getting your mail from. If your mailman's infected and coughing on your letter as they're delivering it to your house and you open it immediately, then I guess theoretically, yeah, you could. I think the risk is relatively low. It's certainly lower than going out into the community right now and going to the grocery store, I think, because you're just exposing yourself to that many less people. So I would be I'd be hesitant to suggest that people not check their mail and not pick up packages off their front porch. But To be honest, I might leave that Amazon package on my porch for a few more hours before I pick it up from now on.
Just let it sit in the sun for a minute. I'm picturing people taking their mail into the sauna with them as soon as it's delivered now, not opening it for a few hours, sitting in the sauna.
That might be you, Matt.
And they've got, I'm picturing getting like a package, a box, and I don't know what's in it, taking it to the sauna and realizing it was some dark chocolate that was delivered, and then it's like running out the edges.
Some of us don't have saunas, Matt. We don't have that luxury, but we could put it in the sun. Yeah.
But I mean, I'm thinking right now too about people are thinking, okay, can I put my letters in the microwave? I don't know. If it's got metal clips on it, it's probably going to destroy your microwave. Can I heat the oven to 150 degrees and put it in the oven? I don't know. I would encourage people to be safe and not cause house fires and things with this information as well.
I don't know that our liability insurance covers you suggesting people put their mail in the microwave, so let's hold off on that one.
Only if it has tinfoil. So let's be really specific, though. It does seem like most of the virus is getting shed and spread by people who are actively carrying it and through direct respiratory droplets at like 6 feet. So the reason we recommend social distancing, just to kind of put things in perspective, is that 6 feet rule is where most people are getting it from another human being who's actually carrying it. So yeah, I agree with you, Mike, that this is like a theoretical risk, but probably the more important take-home message here is still stay away from public places and don't share this.
Yeah, but people are thinking about it and asking it, so we wanted to answer. So it sounds like the consensus is if you're getting delivered to you an infected human, then yes, you could definitely get this through the mail. Otherwise, it's very low risk, but it's not impossible. You could live a few hours. We have a long list of other questions. I'm going to have Trey, our head health coach, and Dr. Stitch are going to go through those and answer all of those, but it's too long for everyone. Everyone is probably not answering all of these questions, but we are going to post that video, the FAQs with the answers, not just the written answers, but we think some of these explanations are important too. So we're going to put the video on our website at wildhealth.com if you're interested in these other questions. But I think those are the biggest ones that people, are there any other, Trey, that you think we definitely should answer for everybody? Or
yeah, talk about supplements for kids.
Children. So we're actually planning on doing a specific podcast about children and coronavirus in the next couple of days. So we'll address that then, what kind of supplements. But we'll have it on the FAQ that you all record as well. Tomorrow we're also going to be talking about, Mike, we can talk about the specific SNPs related to the coronavirus.
Yeah, there's. I just recently came across a new SNP that's really interesting, and it's been related to increased risk for COVID-19. It's RS12252, which is on the gene IFI-TM3. So don't know all the specifics yet, but I'm going to be doing a bunch of research on that this afternoon, and we'll record something on that later this evening or tomorrow morning for everyone.
Great. So go to wildhealth.com if you want the rest of these frequently asked questions. We're going to very soon be doing another testing update. Dr. Bright's working in the lab really quickly on that. We're going to continue to update you on treatments as new evidence comes out. There's studies published every day. We'll do a podcast specifically about children in the next couple of days as well. Thank you all for listening.
Thank you.
Thanks.
Thanks so much for listening. You can continue to tune in for updates throughout the day and every day. And feel free to share this with anyone who you think would benefit. You can follow us on Instagram or on Twitter at WildHealthMD for written updates and summaries if you can't listen in. And you can refer to wildhealth.com, where we'll be collating our updates all in one place.